when you look at the dose of vitamin C, so I am a medical doctor, but I'm also a medical doctor homeopath. So both sides of these, if you will, almost kind of like a left brain, right brain, I have a perspective of being able to see both sides of this fence and recognizing the impact of both sides of this process. And so from a conventional standpoint, looking at the way a lot of people use vitamin C, let's use cancer, because obviously that's what I do on a day in and day out basis, but understand this applies across the board. If you have autoimmune disease, you have diabetes, cardiovascular disease, you're just focusing on wellness, it applies. If you're taking everybody and treating them with the same dose, the same rapid infusion rate, patient that's 6'6", 366 pounds, sitting next to a patient that's 5'2", 110 pounds, and they're both getting 50 grams vitamin C pushed in over an hour. From a purely outside standpoint looking in, any well-trained scientific physician would go, that just doesn't seem right. Because you know that just simply by the difference in body size, there's going to be distribution of that drug. Welcome to the Practicing with Dr. Nathan Goodyear podcast. I'm the medical director at Brio Medical in Scottsdale, Arizona. I am both a conventionally trained and licensed medical doctor as well as a licensed medical homeopathic doctor. This podcast is your resource for a scientific-based discussion of all things cancer and beyond from a natural, holistic, and integrative perspective. It's time to teach the body how to heal. So here we go. All right, welcome back to another podcast. I am Dr. Nathan Goodyear, and this is the Practicing with Dr. Nathan Goodyear podcast. You know, it's really interesting that as we launched this after the first of the year, that, really just building this podcast, this information, this empowerment of natural, holistic, and integrative evidence around wellness treatments, cancer treatments, to help patients understand that the science is there. The science leads the way. We just got to help empower people through a further understanding and awareness of the science, and that includes obviously a lot of conventional doctors. Many of the patients are there. The conventional doctors are not. Institute of Medicine looked at an article, actually Institute of Medicine published an article back in 2001 showing that the average physician was practicing at a level that was 17 years behind the science. Now that was 2001. Imagine what it is now 22 years later in the world of AI, right? And we won't even go down that rabbit hole and what that potentially means. But, we've had roughly 5,500 downloads per month with the podcast. So super excited about that. For all those, I hope it's empowered you and made you aware as I've gone down these, nerdy, geeky rabbit holes as it relates to the evidence around natural, holistic, and integrative therapies, whether that be in cancer or in other chronic diseases of aging. But what we want to do is we want to really build the movement even more, because we need to empower not just people locally here in Arizona, in the Southwest and the West, but throughout the country, North America, South America, and the world. So what we need is we need more subscribers. So I encourage you to subscribe to the podcast, so whenever we drop new podcasts, you are automatically alerted to that new podcast. So look for more and definitely subscribe to see the more. I was talking with my producer the other day, and I didn't realize we've not talked about vitamin C. And for me, it's something that I've been talking about for a long time, because when you look at the world of integrative medicine, especially as it relates to cancer, but even outside of that, the flagship therapy, whether right or wrong, it's vitamin C. And when you look at it in the treatment of cancer, it's absolutely vitamin C that is the flagship. And what's so honestly amazing about it is that from the scientific world, from the conventional medicine world, they're completely oblivious, and I would say in many ways ignorant, of the science behind it. Now, whether that ignorance is intentional or unintentional, omission or commission, I think that's a topic for another time. But what I want to do today is basically, let's present a little bit of that flagship, vitamin C, because I want to highlight a couple studies at the end that really bring together the concept of therapy stacking. See, Paul Ehrlich, he was a chemist back in the roughly late 19th century, early 20th century. he brought forth many things, one of which was chemotherapy, the use of chemicals to treat disease. In that case, it was syphilis, neurosyphilis. But he also brought the theory that is the magic bullet theory, that one thing causes a disease and thus one thing can treat the disease. And that is the flawed paradigm that has dominated medicine, conventional medicine, for the last 100 plus years. And it is a failed paradigm, and it's one that needs to change. So stacking therapies, or therapy stacking, is the combination, sequencing of therapies guided by precision, advanced diagnostic evaluation, looking at genomics, epigenomics, transcriptomics, proteomics, metabolomics, immunomodulomics, hormonomics, microbiomics, and whatever omics. So these are some of the testing that we'll do, for example, in the precision peptides, but it applies here, the stacking, for this example of vitamin C and magnesium. So just two therapies stacked together, and I'll highlight that. But got to lay a little bit of groundwork. And the producer said, we need this to be a little bit short. And I said, oh, yeah, we'll try. So let's focus on a little bit of some fundamentals here as it relates to vitamin C. Now, vitamin C has a lot of different names. And it really, functionality has a lot of different, I think, ways that you can describe it. One is vitamin C itself. Vitamin C, right? Vitamin. By the way, vitamin is going back to something that doesn't have really anything related to vitamin Z. It's just in an old theory process, looking at things that they thought were vital for life, and these amines they thought were the process that were vital for life, and that's where they got vitamin. Interesting concept, but again, another rabbit hole for another time. The reduced form of vitamin C is also called ascorbic acid. The oxidized form is dehydroascorbate. Vitamin C is essentially a electron donor. So it's important in a buffering system that's called the reduction oxidation buffering system. Very important. And in that is where vitamin C's anti-cancer effects can be found, or its pro-cancer effects can be found. I may have just blown your mind, but it's about understanding pharmacokinetics. It's about understanding the scientific principles that guide a lot of the regular conventional medicine therapies, but yet we forget that these apply to natural therapies. So beyond electron donor, you could actually say vitamin C is a drug. It's a prodrug through its production of hydrogen peroxide. And then in proper administration, it can become pharmaceutical ascorbic acid. It's really interesting. Linus Pauling, who many consider the father of vitamin C therapy in medicine, he had a quote talking about fundamentals of vitamin C. He said, although physicians as a part of their training are taught that the dosage of a drug is prescribed for the patient must be carefully determined and controlled, they seem to have difficulty in remembering that the same principle applies to vitamins. Here we're talking about vitamin C. And so those principles that guide conventional medicine also apply natural, holistic, and integrative therapies. And that's one thing I think that a lot of conventional docs are completely disconnected from. I truly believe that they think that in my office, I close the door, I pull out the black cauldron, mix my potion, cast a spell, and off we go. Couldn't be further from the truth. Even in the like, they think that if somebody breaks a hip, I'm going to tell them, hey, let's take more vitamin D. Of course, both of those are absurd. We're just using the science that is already there, following it in the natural, holistic, and integrative mode. So we're not creating anything anew. We're just following what's there. And in that, what's important about the fundamentals of vitamin C is its dose, duration, frequency, the bioavailability, the pharmacodynamics, and the pharmacokinetics. So those two words, pharmacokinetics and pharmacodynamics, really take me back to some nightmares. First year medical school, pharmacology. I can remember making the long trek down the hallway because they would post our scores from tests up on their hallway, and so we would all, as medical students, make our long march down that hallway to see those test scores, where we would go through pharmacokinetics, pharmacodynamics. But Just want to highlight what those mean. Pharmacokinetics is simply the study of time course of drug absorption, distribution, metabolism, and excretion. It's the application of pharmacokinetic principles that apply to the safe and effective therapeutic management of drugs, or here, vitamins, in an individual patient. So basically, pharmacokinetics is just understanding that how the drug is delivered impacts how it's basically distributed to the body, how metabolism affects that, and how it's eliminated. Now, pharmacodynamics is, its definition is the relationship between drug concentration at the site of action and its effect over a time course. So though they're obviously connected, they are, independent from each other, but definitely interconnected. So when you look at the dose of vitamin C, so I am a medical doctor, but I'm also a medical doctor homeopath. So both sides of these, if you will, almost kind of like a left brain, right brain, I have a perspective of being able to see both sides of this fence and recognizing the impact of both sides of this process. And so from a conventional standpoint, looking at the way a lot of people use vitamin C, let's use cancer, because obviously that's what I do on a day in and day out basis, but understand this applies across the board. If you have autoimmune disease, you have diabetes, cardiovascular disease, you're just focusing on wellness, it applies. If you're taking everybody and treating them with the same dose, the same rapid infusion rate, patient that's 6'6", 366 pounds, sitting next to a patient that's 5'2", 110 pounds, and they're both getting 50 grams vitamin C pushed in over an hour. From a purely outside standpoint looking in, any well-trained scientific physician would go, that just doesn't seem right. Because you know that just simply by the difference in body size, there's going to be distribution of that drug. That is pharmacokinetics. And that's in turn going to, in fact, impact pharmacodynamics, whether the impact is positive, negative. And what we have to understand that there's so many other things that contribute to this process just beyond size of the individual. Looking at cancer, it's tumor burden. So how much cancer is there? Is it just a 2-centimeter mass in the liver and that's all that we can see? Or is it we have nodules and tumors all over the place? So the greater the tumor burden, the greater the deficiency of vitamin C, and thus the higher the dosing you're going to need. Also, when you look at people with cancer, they're vitamin C deficient. That's what the literature clearly shows. Already mentioned the weight, metabolic demand. So the more deficient and the longer standing the cancer process has occurred, the more deficiency of vitamin C you're going to see, and the higher impact on metabolic demand and requirement it's going to need when you start adding in vitamin C. There's delivery issues, and that's going to be outside of the context of this talk, but what's the best way to deliver vitamin C in the treatment of cancer? We'll touch on it just a little bit. Redox, reduction, oxidation. This is really key. And this is what ties in with the magnesium and the vitamin C. But vitamin C here is serving as a buffer in the redox potential, in the potential of killing cancer cells or in the potential of actually promoting cancer cells, if not dosed therapeutically. That's the science. And of course, the level of inflammation here is impacting that as well. So patients that have higher degree of inflammation, they're going to require higher doses of vitamin C. So when you give vitamin C IV in the treatment of cancer, you have to recognize that's the only way. If you are going to treat cancer with vitamin C, it cannot be done orally. Period of story, end of discussion. And the reason is because of the poor bioavailability and really the two-phase compartment kinetics involved in this process. So when you look at, let me get down to my notes here, but when you look at the process of how blood levels of vitamin C go, they dictate the absorption. So when you look at plasma ascorbic acid levels, again, that's the reduced form of vitamin C, just a different phraseology, if you will. If the levels in the plasma, that is the blood, are less than, roughly 100 micromolar or 70 micromolar to be exact, the vitamin C is going to be absorbed very rapidly through the gastrointestinal system via what's called sodium-dependent vitamin C transporters. See, there are two types of ways that vitamin C and its metabolites can be taken up by cells and also by cancer. Sodium-dependent vitamin C transporters, of which there's two types, 1 and type 2. Again, not going to go into great detail here, but I want to highlight and lay the ground. And then also what are called glucose transporters, or GLUT. Now, what's important about these as it relates to cancer, vitamin C is readily taken up by sodium vitamin C dependent transporters. But as the vitamin C levels increase in plasma, the sodium-dependent vitamin C transporters decrease. You heard me right. There's a downregulation of those receptors. So vitamin C is converted to dehydroascorbic acid, and free radical, hydrogen peroxide, the ascorbate free radical and hydrogen peroxide, these are then taken up via the GLUT transporters and then reconvened as ascorbic acid inside the cell, and that's a way to bypass it. So these individual receptors are all really important in how vitamin C impacts, cancer treatment. Also understand that with the GLUT receptors, obviously glucose uses those GLUT receptors as well. So glucose with those GLUT receptors is a competitive inhibitor or competitor just in general with vitamin C. So in the process of cancer, they upregulate those GLUT transporters. And so that's a way to use vitamin C in a high dose when you know that with vitamin C, you're going to downregulate those sodium-dependent vitamin C transporters. Rabbit hole, I know, but it's important to understand. And we'll do some podcasts in the future. We'll do much deeper dives on these transporters because they play a very important role here. But when we look at the treatment, therapeutic treatment of cancer with vitamin C, when we deliver it orally, you will never achieve a therapeutic blood level that can kill cancer cells. What we know from the literature is that it needs at least 1,000 micromolar or 1 millimolar to be cytotoxic to cancer cells. The literature has very clearly shown that the oral, even with liposomal, oral, you're only going to be achieving about 100 micromolar. If you add liposomal, you may increase this maybe 2 or 3, maximum 5-fold. So you're not even coming close to knocking on the door of that 1,000 micromolar. And then Dr. Reardon, back in the 80s and 90s, he showed that really plasma ascorbic acid levels between 350 and 450 milligrams per deciliter is really the optimal level of plasma vitamin C levels to actually be cytotoxic or destructive to cancer cells. But does the story end in the blood, the plasma? No, of course not. Because if orally is not doing it, and what's happening is the low plasma vitamin C levels, the gut will absorb it, but as more vitamin C is absorbed and that plasma vitamin C level goes up, that second phase of that compartment kinetics I mentioned, then what happens is the uptake of that vitamin C is slowed as the receptor is downregulated, just like with the IV. So understand there's always this ebb and flow of the physiology, of the biochemistry in the body. It's never sequential. It's never A plus B equals C. It's A plus B equals, FDG, ABC, Z, ZYX. It's a very dynamic, fluid process. But you cannot achieve even close to that 1,000 micromolar or 1 millimolar with oral therapy. Again, part of it's that two-phase kinetics. So you have to move to the IV. That's the only way. And that 350 to 450 milligrams per deciliter basically far exceeds that 1,000 micromolar, and it really comes in at about 20 to 40 millimolar or 20 to 40,000 micromolar. So, but that's just in the blood. Yes, there's cancer cells in the blood. Yes, there's immune cells in the blood. But what happens is that vitamin C must transport across that blood vessel into the extracellular space. The space between the blood vessels and space between that and the cells. Then from the extracellular space, it must reach the tumor microenvironment. Then it must saturate the tumor microenvironment. Then it must reach the tumor as a whole. And then it must penetrate and saturate all the different compartments, the hypoxic and the normoxic area. That is the low oxygen and the normal oxygen area. And both of those exist within that tumor and microenvironment. And of course, you've got the acidity and the alkalinity involved in there as well because of the metabolic issues that Thomas Seyfried and others have described well in the literature. So what we have to do is we have to achieve all of that with IV vitamin C. And you know what? They've actually looked at studies in animals and shown that you can do that. That's the amazing thing, is that the evidence is there. It's like gravity. You walk outside and you go, I don't believe in gravity. It's like, well, test that theory out walking off the 4th floor. So just because a physician says, well, I don't believe in vitamin C, and actually I had a physician tell me that, I don't believe in what you say about vitamin C. It's like, well, I'm not asking you to believe in what I'm saying. I'm just asking you to read the science and recognize it. Because you may say, I don't believe in gravity. It's a go try that theory out and see how that works. Also, just because they don't read it and don't know it's there doesn't mean it doesn't exist. Being on the 4th floor, look out. You don't see any evidence of gravity, right? But you take that step and you see it firsthand. So when you look at the dosing of IV vitamin C, before we jump in here in a second with these 2 studies, is you have to really understand that there's 4 very critical principles that guide appropriate therapeutic vitamin C treatment in cancer. And this applies again. Take your autoimmune disease, chronic disease of aging, cardiovascular disease, just take your pick. It's bioavailability, which obviously what I mentioned there, the oral is not bioavailable enough, but with IV it's 100% bioavailable. It's about dose, which I've described many different parameters that affect the dose. There's frequency, so it's not enough to just dose, but it's frequency. Let me back up just a little bit and talk about dose. When you look at high dose vitamin C, okay, what the literature tells us is that it starts at 1.5 grams per kilogram of weight. So you take your weight in pounds, divide by 2.2, you get kilograms. So when a patient comes in my office and, we take their vital signs for their first visit, if I'm going to put them on vitamin C, I calculate the vitamin C dosing based on their weight divided by 2.2 gives me the kilograms, multiplied by 1.5. That's the starting dose. Because then what we do is we follow the plasma ascorbic acid levels to see where that level comes in, because it's going to come in different based on the inflammation, the redox imbalance, the tumor burden, the body size, the metabolic needs. All of that's going to affect it. So that's where it starts. So you may be going up from there. And let me tell you what, I haven't met a patient yet that their dose starts at only 50 grams. The smallest I've ever started was about 78 grams. And obviously most people, and the size here in the US, it's much higher. But that's where it starts. But then you have to go up. You have to calculate as you go up, as you reassess. Because if you have high blood pressure, you take a blood pressure medicine, you go back to your doc, what's he going to do to evaluate it? Recheck your blood pressure. So we have to check the vitamin C levels in the blood to assure that that dose is giving us what we need. That's dose. Frequency. It's not enough to just dose one time. They actually looked at literature. They actually looked at animals and showed that in healthy cells, the vitamin C is cleared within minutes. But within the body, in 16 hours, it's completely gone in healthy cells. Completely gone. But in cancer cells, what's interesting, as it takes it up, it holds on to it much longer. So you can still have therapeutic levels of vitamin C in cancer cells up to 48 hours. Whereas in healthy cells, 16 hours, it's completely gone, and most of it's gone in 2. 2 different environments, 2 different effects of vitamin C. It's what I used to call the dualistic principle, but it's a principle of Trinity, which is that natural therapies really will target unhealthy cells, here where it's cancer, but its impact on healthy cells is one that's not destructive. It's actually one that promotes healing. So different environments dictate different effects. So right there, we've talked on oral versus IV, bioavailability, dose, critical based on those different parameters that I mentioned, and then frequency based on that literature. So that's why, interestingly enough, when you look back at vitamin C literature, a lot of the significant clinical anti-cancer effects are lost when vitamin C dosing goes below 2 times a week. But according to that literature, 48 hours, that's 3 times a week, and sometimes even more. And then duration. And this is an area that I see many physicians not understand and apply in the clinical setting. When you're treating cancer or any chronic disease of aging with vitamin C, it's not just the dose delivered, it's the duration of that dose as administered and frequency of dosing. Duration is the one part that nobody follows. Giving 100 grams of vitamin C, let's say, based on the high dosing 1.5 grams per kilogram, and you rush that in over an hour, first of all, you're going to make it so the patient just can't tolerate it. But second, you're expediting the elimination of that vitamin C. It's not just dose, it's about the duration of that dose. It's about the half-life. What we need from the vitamin C anti-cancer effects is not just a 1-hour window or a 4-hour window. We need a 48-hour window of cancer killing impact. So this brings me to the concept of these two studies, or the topic of these two studies, okay? Because when you look at vitamin C, the question is, what's the right dose? Is it low dose? Could be. But I would tell you, literature says no. Is it high dose? Is it pharmacologic dose? Is it therapeutic dose? What I would say is it's the right dose dictated by the effect that you want based on those pharmacokinetics, pharmacodynamics that are impacted through the bioavailability, the dosing, the frequency, and the duration. And understand, this is just simple pharmacological principles that are not anything new, that are just being applied to natural therapies, holistic therapies, integrative therapies. It's not that they're being applied, they're already there and they're already published. So it's not anything that we need to really reach outside the box on to really understand a lot, beyond that. This is evidence-based. Yes, it's vitamin C. Yes, it's the flagship of natural holistic integrated medicine, but it is very much evidence-based. So I want to touch on two studies here. First one is entitled Hormetic Dose Response to Ascorbic Acid as an Anti-Cancer Drug in Colorectal Cancer Cells, Cancer Cell Lines, according to the sodium-dependent vitamin C type 2 expression. This study was from 2018, and so what they found is that the sodium vitamin C dependent transporter type 2 functions as an ascorbic acid transporter, as I mentioned earlier. And the anti-cancer effects of vitamin C here, they called it ascorbic acid, are proportional to the sodium-dependent vitamin C transporters. So the more the sodium-dependent vitamin C transporters were expressed, the higher they were expressed, the more anti-cancer effects of vitamin C were seen. And what they said, the authors here said, is that the vitamin C has a biphasic role in cancer cells depending on the ascorbic acid uptake, which in turn is dependent on those sodium-dependent vitamin C transport expression transporters, meaning there's a biphasic response dependent on the dose of the vitamin C and the level of the vitamin C transporter to uptake it. So if we have low vitamin C delivery, or if we have low sodium-dependent vitamin C transporter, that's going to impact the uptake of vitamin C by the cancer cell, and that's going to impact the anti-cancer role. So biphasic, meaning that's hormetic. That's what hormetic means. It means the dose is dictating a different response. So everybody looks at vitamin C as saying it's all anti-cancer. Is it? Literature says it's not. And so from a conventional perspective, if docs are treating everybody the same, that's unscientific. It's unevidence-based, based on just simple pharmacodynamic and pharmacokinetic properties of what we know about vitamin C. And what they also found in this first study is that there was if there was sufficient concentration of the vitamin C to generate reactive oxygenation species, that's what was killing the cancer cells. So the more vitamin C that was in the blood, that was uptaken by these transporters because there was high expression, it was overwhelming these cancer cells with oxidative stress. That's a reactive oxygenation species. And it was overwhelming the detoxification capacity of these cancer cells to induce a detoxification crisis, good literature to describe that, as well as an energy crisis. So what happens here, it's depleting of glutathione. This is why I don't advocate for glutathione in cancer, even in acetylcysteine. But it depletes it of NAD and thus creating an energy crisis. That's why I don't like NAD in cancer either. So that they found that the expression of the sodium-dependent vitamin C transporters and the vitamin C were critical to achieving that cancer cell destructive reactive oxygenation species impact to destroy the cancer cells. And this was easily seen in the high expression of these transporters, the sodium-dependent vitamin C transporters. But what's interesting is in the high sodium-dependent vitamin C cell lines, let me rephrase that. In the high sodium-dependent vitamin C expression in the cancer cell lines, ascorbic acid showed growth inhibition and triggered cytotoxicity through apoptosis at all concentrations of the vitamin C when those receptors were highly expressed. Meaning the more doors that were there at all levels of the vitamin C, it was going to open all those doors, go in, and kill the cancer cells. Okay. But when there was a low number of doors, and there was low delivery of the vitamin C, it actually promoted cancer growth. So, dependent on the number of doors, that is the sodium-dependent vitamin C transporters, that was dictating whether the vitamin C dose was killing cancer cells or promoting its growth. So, really a different thought process than most are thinking about, because everybody's thinking that vitamin C, no matter the dose, is killing cancer cells. But what the literature actually shows is that it's a lot more complex than that, and if you're not following those basic pharmacological principles, you could actually be promoting cancer growth. And I don't think that's anything anybody's wanting to do. So what we have to do is lead with the science so that when conventional doctors say, I don't like this vitamin C stuff, well, there's points where vitamin C is delivered by other practitioners out there that I would agree with them because they're not following good scientific principles. Being in a natural, holistic, and integrative arena of medicine does not mean we run from science. In fact, it's the science that leads the way. We're just simply following it. So this then brings me to the next article that was published in 2020. Enhanced anti-cancer effects of adding magnesium to vitamin C therapy. Inhibition of hormetic response by sodium vitamin C2 transporters and their activation. So now the concept, we've laid this groundwork of this deep pharmacological principles of vitamin C at a very basic level. Again, getting the geek on. But now we're stacking therapies because we already showed that, hey, we can deliver vitamin C levels, IV, and in the blood. But if there's a lot of doors there, you bet it can go kill cancer cells. But if there's just a few doors, we may actually, if we don't dose appropriately, we may promote cancer growth. So along comes magnesium. In Translational Oncology is the journal in 2020. What they found is that magnesium ions are known to activate sodium-dependent vitamin C transporters type 2. And magnesium supplementation enhanced the anti-cancer effects of vitamin C by inhibiting that hormetic or biphasic response of vitamin C at a low dose. See, if you have low sodium-dependent vitamin C transporter and you're not delivering adequate vitamin C, you're getting low vitamin C delivery that's promoting the growth. Magnesium is counteracting that biphasic hormetic response. So vitamin C treatment with magnesium supplementation actually in this 2020 article provided more effective anti-cancer therapy than vitamin C alone. Now why? Why is that? Why is the stacking of these therapies counter to that principle that Paul Ehrlich brought forth in the early 20th century, the magic bullet theory? It's because it's not the reality of physiology. You got to bring things together. You got to stack therapies together. Magnesium ion supplementation increases the vitamin C uptake activity of those type 2 sodium dependent vitamin C transporters. So you may have fewer doors. And so that vitamin C delivery is getting backlogged and just blocked from going through all those doors. And that is then what would promote the growth. But magnesium comes in and helps to funnel that vitamin C in because of those low number of doors. And so in this 2020 study, what they showed is that adding magnesium to the vitamin C solution given IV enhanced the anti-cancer effects of vitamin C by increasing the vitamin C transport activity of those sodium-dependent vitamin C transporters in the cancer cells at both high and low levels of the expression of those sodium-dependent vitamin C2 transporters. So meaning when you have cancer cells, whether it's high expression of those SVC2 or sodium-dependent vitamin C type 2 transporters or low expression, adding in the magnesium with the vitamin C is going to inhibit that biphasic hormetic response and ensure that we're going to achieve maximum vitamin C uptake by that cancer cell when dosed appropriately, following all of those understanding of bioavailability, dosing, duration, frequency. So their conclusion was co-treatment with vitamin C and a magnesium supplement, here it was all in IV, showed more effective anti-cancer activity in cells with low sodium vitamin C transporter type 2 expression and then in cells with high expression. So at the high expression of those sodium-dependent vitamin C2 transporters, the dose of the vitamin C wasn't as important. But remember, the higher the dose of the vitamin C, the more the duration, the more the frequency, you're going to get downregulation of those sodium-dependent vitamin C2 transporters. So this is going to come in to question with every patient receiving vitamin C therapy in cancer or likewise other diseases. So then as we get a downregulation of those vitamin C2 transporters, or if the expression is by itself out of the gate low on these cancer cells, then we must have magnesium added to help funnel more vitamin C in. If not, we will actually potentially propagate the growth of the cancer cell. See, we must lead with the science. We must be in the literature to understand the science. It's great to help patients heal, but we must help other practitioners that are using vitamin C as a natural, holistic, and integrative therapy use it more evidence-based, because in that they're going to be more effective and they're going to help more patients. But also what's going to happen is more doctors are going to start to understand that there's science behind natural, holistic, and integrative cancer therapies. We don't just throw darts up on the wall and hope they stick. We are following precision-based multiomics, and here we're targeting the therapies to actually improve the efficacy of a natural therapy simply by stacking magnesium with vitamin C. But we're doing it in a way that is following the science. A 2018 article, a 2020 article. So a little bit of a deep dive, a little bit of some rabbit holes there, but as the producer said, we hadn't even talked on vitamin C. I can just keep talking and talking and talking about vitamin C because I have for a long time, simply because it is that which we must defend, because it is the flagship. And so when those that are opposed to natural, holistic, and integrative therapies, they want to target and take it down. But there's science there. And what we cannot let those that are out there that are against these therapies do is two things: say this is unscientific, that there's no evidence, or two, change what we can say about it. Words have historical context, and we must understand that the origin of these words and the meaning of these words, we must hold true to them. We must preserve these natural, holistic, and integrative therapies because they are evidence-based, they are scientific, and they are effective when applied as such. Now, any therapy, conventional or not, if not applied according to the evidence, won't be effective. By using these therapies by the evidence, we elevate the whole movement of natural, holistic, and integrative science. That is medicine in the treatment. Here I'm talking about cancer. So this is just two highlighted studies. I hope it's been helpful. And we'll do some, deeper dives on vitamin C in the treatment of cancer and other disease states or just in wellness in the future. But I thought these were just some good articles to highlight. So again, as I mentioned at the beginning of the podcast, we're averaging about 5,500 downloads a month. But, we think we can do more to impact more lives, more patients' lives, more doctor practices. To do that, we need you to sign up so that when we drop new podcasts, like what we just dropped the podcast where we did the 3-part series of Dr. Donato, The Legacy of IPT, you'll be notified and you can know right there, it's in your inbox, wherever you find your podcasts, to listen and learn and share. So I'm Dr. Goodyear from the Practicing with Dr. Nathan Goodyear podcast. You can check me out over at drgoodyear.com, on Instagram, dr.goodyear, or wherever you on social media look to find us. You will find us there. Also check us out because we're doing a lot of publications in the general media across the country, and we look forward to sharing information with you, empowering you with the evidence, the science behind natural, holistic, and integrative cancer therapies. I'm Dr. Goodyear. Until next time, we will see you soon. For more information just like what we discussed today, I encourage you to follow us on YouTube as well as all of your favorite audio streaming platforms. And in there, we'll talk about all things related to healing, wellness, cancer, and much, much beyond, because it doesn't just apply to cancer. Our goal here is to turn to healing, restore health, and promote your wellness, whether that greatest obstacle to wellness being cancer or any other named disease. Our goal is your wellness. I'm Dr. Nathan Goodyear, and enjoy our future podcasts at Practicing with Dr. Goodyear.